Good morning, Veena. How are you? You're muted now.
Hi, am I audible now?
You're very well audible.
How are you,
How
ma'am?
are you?
I think shall we then move on to the presentation without any delay?
Yes, yes.
So good
I'll
morning.
start sharing.
Yeah, 1 minute. I'll just introduce you. Give me 1 minute to introduce you, and then you can go on to the presentation.
Sure, sure.
Very good morning, everyone. Today it's my privilege to introduce Dr. Veena Vedartham. She is one of our alumnus. She works in Bangalore in Manipal Hospital as a neuromuscular specialist. She has done her DM from Sri Chitra, and after that she completed her fellowship in neuromuscular disorders from University of Toronto, Canada, under Dr. Brill, and she's one of the more brilliant people I've seen in my life. She'll be taking us through the newer therapies in myasthenia gravis, which have come up in a big way in the last half a decade or so. So now I hand it over to Veena to take it forward.
Thank you, ma'am. Thank you for the introduction. I hope you can hear me clearly, isn't it?
Yes, yes.
Yes, we can.
Yeah. Okay. Okay. So I'll just start sharing my slides. Can you see my slides, ma'am?
Yes, madam.
Yeah. Okay. So good morning, everyone. It's truly wonderful to be back, even if it is virtual, with my alma mater. And I'm here to present to you about the new therapeutics in myasthenia gravis. Let's take it further. So today I'll discuss about the three main mechanisms which have been in vogue recently and drugs related to those, certain meta-analysis of all these drugs, and where and when do we use these new drugs. So back during my MBBS days, when I was reading about myasthenia gravis during physiology, the one thing that I always knew was, okay, the impulse doesn't pass across the junction. So there's an antibody which blocks the receptor, and there is a sodium influx that doesn't happen, and this prevents muscular contraction. As the time went by, I also realized with lot of reading probably and lot of studies that came across, it just does not cause blocking, but there is a lot of destruction of the folds. There is modification of whatever the muscle synapses. There's so many other things which happen, not just the sodium influx. During this point in time, we also understood there is something else which causes production of these antibodies, which is the thymus, where there are certain autoreactive T cells produce B cells. They stimulate the B cells to produce these antibodies. There's a lot of complement activation. This is where we were standing back then. But as things went by, the junction came to a corner, and there's a lot of other things which came up. And our studies on these have actually helped us in identifying drugs which will help all our patients with myasthenia gravis. So, what we also know is that this is from our basic immunology, microbiology point in our MBBS and those days, where there is obviously an antigen presenting cell which binds to T cell, then that stimulates the B cell to produce certain antibodies. There is also a lot of plasma cells which are triggered, and these produce those antibodies. These antibodies go and act on the junction. They change the way the junction is, they change the way the receptors work, and then finally that is when the patient actually starts having symptoms. Now there are a lot of mechanisms, lot of drugs that have come up that are going on in research. There are a lot of research also going on, not just with respect to myasthenia but various other immunological diseases. Right now what I think is there are so I will not focus on all of these 100 drugs which are there. I will talk about three new mechanisms. Those are the mechanisms which are approved to date. There will be more to come, but let's not get confused with too many things at a time. So we'll talk about these three mechanisms and then take this discussion further. This is a prototypical case, a 42-year-old lady with 5 months history of ocular symptoms, easy fatigability, acetylcholine receptor antibodies positive, CT thorax is normal. What is our next line of management? There are various guidelines now which have come up, which were not there in the past, but have come up 2020, 2023, 2024. Now, recently, there's the British Neurologist Guidelines. But the gist of it, it doesn't really change much. You diagnose somebody with acetylcholine receptor antibody positive myasthenia. You start on symptomatic treatment. Start on first line or second line alternatives such as steroids, or based on what that patient had, what you think is best, probably azathioprine or mycophenolate, or rituximab if it is a mask positive myasthenia. But if it is acetylcholine, you still start that. If at all the patient is not responding, then you go to a second line immunosuppressants. If there is this thymus which is detected, or if the patient is below 50 years of age, you go ahead and do your thymectomy. When there is a crisis, you try to give your rescue treatments. It hasn't changed much, but let's see what the role of these new agents is. I had 4 questions. When I was preparing these slides, I had 4 questions which I thought should be answered by the end of the session. Is it only for cases that are refractory? Are these new agents only for the refractory myasthenia gravis patients? Can we use them as first-line agents? Can we taper and stop steroids while the patients are on these newer agents? Are they better than the older ones, such as azathioprine or MMF? Now, the 3 mechanisms which have shown benefit for now are complement inhibition, FcRn inhibition, CD20-19 inhibition. Let's deal with each of them. Now, complement inhibition, you know the complement pathway, we know the alternative pathway, classical pathway, lectin pathway. They finally go on to the C5. I'll just put a pointer, C5. And the C5 basically, again, gets divided into C5a and C5b. C5b, which goes on to become the membrane attack complex and destroys the membrane. C5a is again a pro-inflammatory and pro-inflammatory product, I would say C5a. This again causes a lot of pro-inflammation and inflammation and causes destruction. Now, what is eculizumab? Eculizumab is the first complement inhibitor, which is basically a combination of a human and murine structures. It basically, what it does is, it's a monoclonal antibody. It goes and binds to this C5 convertase. It inhibits the conversion of C5 to C5b and C5a. So finally, a membrane attack complex is not produced. There is no inflammatory reaction. And then obviously we would expect good amount of problem solving at this point in time. So this is the first study which was done. This was the study for eculizumab, which is called the REGAIN study. What they did was they gave 900 milligrams of eculizumab every week for the first 4 weeks, then 1200 milligram at week 5, and after that 1200 milligram every second week thereafter. And they tried to score the improvement based on our usual scales, which we use in myasthenia gravis, which is MG-ADL, QMG, MG clinical score, and quality of life score. What they have noticed was, as compared to the placebo, the red is placebo, the blue is the red is placebo, the blue is eculizumab. What they noticed was by week 1, there has been shown to have an improvement in the ADL scores and the QMG scores, and this improvement tends to last for quite some time. Then they went on to, after the 26-week period of the REGAIN first study, they went on to do an open label extension study where it went beyond week 52. In those patients, what was very interesting is, yes, these patients, whoever have responded, had kept responding to eculizumab, but they also saw that certain patients who did not really respond in the initial few weeks, which is around 12 weeks, that is what the average that they found, they also started responding later on. So this was where eculizumab was found to have a very good benefit in all these patients with myasthenia gravis, mainly the acetylcholine receptor, and it was FDA approved in 2017. Now then came, so this eculizumab, the problem with it was you need to give this medication once in 2 weeks. Now they engineered the molecule. They tried to create a monoclonal antibody which acts against acts in acetylcholine receptor antibody positive myasthenics. They engineered the molecule, tried to substitute certain amino acids, and produced another molecule which is ravulizumab, which can be given once in 8 weeks. So this is an 8-weekly dosing regimen. And they had also seen that in this particular complement inhibitor also has had very good improvement in the MG-ADL scores, QMG scores, and quality of life scores, as you see in all these graphs, where the blue is the ravulizumab and as compared to the placebo, which hadn't shown any improvement at all, ravulizumab had shown improvement by around second week. You're not able to see because of this, but then by the first week itself, they had started noticing an improvement. And when they did this open label extension on this particular drug, which went beyond 138 weeks, they had noticed that when the patients who were on placebo, when they were converted to ravulizumab, they had also started responding, and the response kept on going well, and the patients did well. Now, this ravulizumab was approved in 2022. What was very interesting with the study was that they also tried to see if these patients, whoever had taken ravulizumab, were we able to reduce the dose of steroid. What I would want you to do is focus on this sky blue colored box in the bar, which is basically those patients who have sky blue color, and above that, the brown and the gray. These are the patients who have had steroids at more than 10 milligram per day. In all these patients, the number of patients who were taking, the proportion of patients taking more than 10 milligram per day kept decreasing as the time went by during the open label extension study. So this also says that ravulizumab, that basically we will talk about ravulizumab and the complement inhibition, has a steroid sparing effect also. Now, these medications are IV. You have to take it, the first one obviously once in 2 weeks, the second one once in 8 weeks. Now they came up with another formulation which can be subcutaneous and can be self-administered. This is a microcyclic peptide. It again binds to C5, prevents its degradation to C5a and C5b. It also binds to C5b, so it basically inhibits the formation of the membrane attack complex. Zilucoplan, it is zilucoplan. Even in this, they had noticed that the improvement starts by 1 week, and the improvement is sustained, and it goes on during the open label also. It went on to, it continued to be there. They had also seen in this study also, they had seen that 41% of patients discontinued or reduced the dose of corticosteroid with a mean dose reduction by around 14 milligram percentage. So this again in 2023, zilucoplan also got approved. Because this acts on complement, because all these inhibit our complement, and complement is very important for for infection, to help us against infections, especially for capsulated organisms. So that is why there is a probability of these patients are at a high risk for meningococcal, gonococcal infections. So what is recommended is, if you plan to start these medications, you have to vaccinate these patients against all these infections, and then you go ahead and start it. Other than this, there is no other major side effect found. Now let's come to the second mechanism, which is FcRn. Now FcRn, these are FcR receptors. These basically receptors bind to IgG and they help in phagocytosis, complement activation. There is a group of FcR receptors which help in activation of the inflammation. There is one receptor which acts in inhibition of the inflammation. There is one receptor which basically increases the half-life of the IgG. That is the receptor which we are targeting now, which is called the FcRn receptor. No, in order to understand what happens with FcRn, so I've taken a thing with the intestine where, see, there is an antibody. Are you able to see the slide, or is it not seen well?
Yeah, we can see.
Seen. Okay.
Okay. So now so this is the intestinal epithelium. There are certain antibodies here. Okay. There are certain antibodies here. So these antibodies have to go into the intestinal epithelium and then into the blood. So how does it happen? It happens through these FcR receptors. These FcRn receptors, if you see those green receptors, they basically help in internalizing these antibodies into the epithelia and down into the bloodstream. Now, when they reach the bloodstream, they get exposed to dendritic cells. So these dendritic cells, so once they go into the dendritic cells, FcRn again basically there are certain other FcR receptors which take up these antibodies. And what exactly is the role of now FcRn? As I was telling you, it tries to prolong the half-life of the antibody. So what it does is it keeps the antibody bound. It resists the degradation by the lysosome, so much so that the antibody is safe enough, and then it goes into the circulation and helps in production of immunity and immune responses. Now, basically, what we understand here is FcRn tries to prolong the half-life, prolong the health of the antibody which is there. But we don't want these antibodies in patients with myasthenia gravis, especially the antibody myasthenia gravis, antibody-positive myasthenia gravis. So, what they tried to find was if we can inhibit these FcRn receptors, if we can do that, then probably the antibodies will get destroyed. So the FcRn receptors, so the FcRn inhibitors were thus formulated. So what you see here is the orange colored one, which is the FcRn inhibitor. So and this green one, as we saw, is FcRn receptor, and this is the antibody. So what happens is, as we all know, it is taken into the endosome. In the endosome, instead of binding to the FcR, it binds to the FcRn inhibitor, and the antibody gets degraded, and then goes through the lysosome and is gone. Now the FcR inhibitor gets recycled. So what we see is the antibody gets degraded here into the lysosome and is gone. So this is what they're trying to do with all these medications. So the first medication, the first drug which was found which would help in inhibiting the FcRn was an engineered fragment. It's an engineered Fc fragment of the human IgG, and it basically can be given weekly as an IV preparation. Okay, weekly in IV preparation as 10 milligram per kg body weight, and it can be given in both acetylcholine positive and negative. It was seen in both these patients. As I was telling you in the other slide, so in place of that FcRn inhibitor, we're basically seeing the efgartigimod, which binds to the FcRn instead of the antibody. The antibody goes into the lysosome, gets degraded, and thus the levels of the circulating IgG decrease. So what was seen in this ADAPT and ADAPT Plus study was that all these patients who had received efgartigimod had significant improvement in their ADL scores and the QMG scores. They had seen that the improvement starts by week 1, and the patient had to obviously had a significant improvement as the cycle was going on. But most of these patients obviously needed recycles, because once the cycle was stopped, they will obviously go back to the baseline. So the need for continuing this basically says that it is effective, but also it needs a longer term treatment and has to be continued in these patients. And this particular agent was approved in 2021. There was also, this was the IV preparation which was approved. Later on in 2023, the subcutaneous preparation was formulated so that it can be self-administered and by the patient himself. So this subcutaneous preparation, when the study was done, the study is again ADAPT subQ. So it was also seen that it is the effect is equivalent to the IV formulation of efgartigimod. Similarly, the graphs all show that as just like IV efgartigimod, subQ also had a significant benefit in the MG-ADL scores. Coming to the second one, which is another FcRn inhibitor, but it's a humanized monoclonal antibody. The first one was an engineered fragment. This is a humanized monoclonal antibody that blocks the IgG binding region of the FcRn. So this is basically called rozanolixizumab. The study is basically myCARN G and its open label extension. Here they had included both the patients with acetylcholine antibody positive and MuSK antibody positive. And the dosing regimen was 7 milligram and 10 milligram per kg body weight. This is the dose that is recommended now. It's based on the weight. For less than 50, it is 420, 50 to 100 is 560, more than 100 kgs is 840. And this particular medication has to be given once a week for 6 weeks. And subsequent cycles are to be decided based on the further clinical evaluation, based on how the patient is doing. Even in this FcRn inhibitor, it was noted to have a significant benefit. This is the treatment period, and even in the observation period, the treatment, as the cycle was continued, the treatment, there was an improvement in all those scores with respect to myasthenia gravis. The third FcRn inhibitor, which has been approved recently in 2025, the open label extension is, the results are still not out yet. This is again a fully humanized monoclonal antibody that binds to and blocks the FcRn receptor. This has been approved both in acetylcholine antibody positive and MuSK antibody positive. What is very different about it is it has been also approved in pediatric patients more than 12 years of age. This again, the dosing regimen is loading dose of 30 milligram, then followed by maintenance dose of 15 milligram per kg every 2 weeks. Again, as compared to the placebo, the response had started by week 2, and the patient had sustained improvement in his symptoms. The third mechanism is CD20, CD19. These are two different mechanisms. I had put it in the same column in order to give you the perspective. So the study, which was it's a very wonderful study. We have been using rituximab many a times in many of our refractory if we didn't have any other option. But then this was a Renomax randomized controlled trial, which was released in 2022, published in 2022. What the study had actually done was they had given a single dose of 500 milligrams of rituximab in myasthenics who had come very early on in their disease process. And they had noticed that those patients who were given this particular dose of rituximab had significant benefit in terms of improvement in their disease manifestations, where the proportion of patients with minimal disease manifestations was significantly higher in patients who had received rituximab as compared to the placebo. But what this study did not meet was the secondary endpoints, which is the QMG scores, MG-ADL scores, and MGQL scores, where it was found that rituximab was not better than placebo. As compared to the placebo, it was not significantly better, and there was no much difference in the QMG score. Again, then came the Beat MG study. This study had actually tried to see, they gave the usual regimen for rituximab. They did not focus on patients who were early in their disease process, but then they gave it and they tried to see what is the steroid sparing effect of rituximab. And they found that rituximab doesn't help in getting the patients out of the steroids, corticosteroids. So then the thought process came to where if we are blocking CD20, we are not actually seeing a significant amount of improvement. Why don't we look at CD19? The CD19 basically gets expressed on plasmablasts, plasma cells, and Probbe cells, which are very important for the production of IgG. So then came this study, which is called the MINT study. This is the drug is ineblizumab, which is a CD19 inhibitor. This was recently published. What they did was this drug was given in patients with acetylcholine antibody positive myasthenia on day 1 and day 15, and an additional dose was given at week 26. So the duration, along the duration, they tried to see what is happening to the patients with respect to the MG-ADL score and QMG scores. This went on to an extension also where 52 weeks was involved, and it was seen that as compared to placebo, the CD19 inhibitor had done really well. There was a significant improvement in the MG-ADL scores, not just in acetylcholine. They had also seen a subgroup of MuSK positive. They had also seen a significant improvement. Now we need to wait for the approval of this particular agent, but yeah, looks like we might get it. They have applied for it in the first half, is what I see on Google. So let's see what happens to this. So these are the three mechanisms which have for now produced certain drugs which have found to have really good benefit in our myasthenic patients. So now, are these trials only in patients who are refractory to treatment? So I made a small table out of all the studies that I found. So what was seen that the studies had included refractory patients were only the first regain study, which included eculizumab as the drug, and the second one was rituximab, which is the BTMG study. But the rest of them, they did not really take people who are afresh or they're naive, treatment naive patients. They did take patients, but they were on stable therapy or somebody on standard therapy, somebody who's not who has not done well with the standard therapy also. So the refractoriness has been seen only, the refractory patients were only included in eculizumab. The rest of the patients were not really refractory for that matter. So maybe we can still use them in patients who are not refractory enough, but they still can be used as a newer, or also in naive, treatment naive patients. Now coming to the meta-analysis, which drug is better? We have three new mechanisms, several new drugs. Which one is better? There is a network meta-analysis which was done. There are couple of meta-analysis which said of the lot, the first would go to efgartigimod. That's the first rank given to efgartigimod. That's the best of the lot. Later on comes the rozanolixizumab, then the zilucoplan, then eculizumab, and last would be rituximab. Then there is another network meta-analysis. Here they had tried to see what is the risk benefit of giving all these drugs, and what they found out was this is basically how many patients, the number to treat to show a benefit with the drug. So it was seen that efgartigimod had a lower number to treat. That means efgartigimod was associated with a favorable profile. It was also noticed that the benefit risk profile was way better with efgartigimod. They also seen there is a better economic value, probably because the improvement was way better as compared to others. Now, when it comes to the role of newer agents, now do we have answers to this? Is it only for cases that are refractory? Probably not. We can still use in patients who are treatment naive. Can we use them as first-line agents? Yes. Can we taper and stop steroids? With respect to complement inhibition, we do have noticed that steroid sparing effect. We do not know with efgartigimod. And are they better than the older ones such as azathioprine? There is no study. But when we look at economic perspective, when we look at what we have done to all our patients still now, patients have done well. Maybe all these patients will continue to be on the conventional treatment. Maybe if you ask me, maybe later on, if at all they do not really respond, or somebody who's refractory, I would probably suggest a newer agent, because the most important thing here is the economics. The economic value, the financial burden to a patient is going to be huge with all these agents, and these agents are not for a period of 6 months or a year. This is going to be for a longer term. So yeah, they might be, they might not be, but then we are still happy with azathioprine and MMF for now. So how would you visualize these inhibitors, FcRn inhibitors and C5 inhibitors in the dosing regimen or in the patient's journey now? So initially, if the patient has a mild or moderate disease activity, I'm talking about generalized myasthenia, you probably give steroids or a non-steroidal immunomodulator, which is azathioprine MMF. If there is a high disease activity, and you can add on FcRn inhibitors or C5 inhibitors. If it is a MuSK antibody positive, rituximab, yes. And now, because FcRn inhibitors have been found to have a role in MuSK antibody, if somebody is not doing well with rituximab, we can add on FcRn inhibitors also. The usual exacerbations and crisis will go on with IVIG and plasma exchange. Okay. I think I am before time. It's already just 8:30 now. If you have any questions, you can let me know.
Thank you, Veena.
Thank you.
I think you have taken us actually through a very practical approach to how we will be able to utilize all these new medications. Do you think any of them are going to come to India in the near future? Because I think nipocalimab, it is being studied in India, but the ones which are already approved.
I mean, right now, I do not know whether they're coming to India and whether our companies have started producing it. But we do see eculizumab here and there, especially our rheumatologists have been using it. So eculizumab is something we have found that it can be brought to India, but then at a high cost.
Because at this point, treating refractory myasthenia, I think we use rituximab quite a lot if there is refractory myasthenia, but we tend to use it with multiple other drugs together, and that sometimes results in quite problems with in sepsis and other kind of infections. We have had especially when they have high dose of steroids along with two uh, anti-inflammatory agents, you tend to have a higher risk of infections. In your experience, where do you place rituximab? Like, do you give it quite early in the course, or do you reserve that for refractory patients?
Right now, so after the Renomax trial, we were very excited. Maybe we should probably use it early in the course. But then when the patients are doing well with azathioprine and mycophenolate, we would put rituximab as a later on agent rather than very early for the time being. Practically, if you look at real clinical practice. But Musk, as we know, Musk is the only one which we give it early on. But rituximab, I really don't give, ma'am.
Okay. So I was about to ask you whether you tend to give it a longer time, or do you would you stop it earlier? But you don't tend to use it much, right?
No. Have you given, ma'am?
We do give, especially refractory we give, and we are thinking of giving it earlier as well to see if, because the entire problem is that with MMF and azathioprine, we are forced to use these medications for like steroid has to be continued at a fair dose for at least 6 months. So with rituximab, we have the
Yeah.
hope that we may be able to bring it down earlier and keep the load of steroids less. That is the entire idea.
Mm-hmm. Yes, yes.
Yeah, so that
If that really helps, that would be great because most of these myasthenics tend to develop steroid-induced diabetes, and most of them are already diabetic. They have all these problems with metabolic syndrome, obesity. So yeah, if we can really come out of steroids, that would be great.
so as a method of coming out of steroids earlier, I think rituximab may be a good idea. And there are, I think, studies, although small ones, which show that early and smaller doses may be enough if you
Hmm.
give it as in drug-naive patients.
Hmm. Yes, ma'am.
I'll open the floor to questions. Are there anything from our residents, or those who are listening online, kindly put some questions on the chat box if you need them answered. So, Veena, the question from Sapna Madam is this: can we give this as an induction to start with and then continue with the oral medications for rituximab?
Hi, ma'am. Don't really know. Maybe because of the faster onset of action, we can experiment, but then we don't really know because all these I mean, at least the newer agents, what the trials say that we need to keep giving it, otherwise it won't work. We need to keep, it is not as if you give today and it works forever. So maybe with respect to the FcRn, we can use it as a rescue therapy or an initial therapy, and later on probably see how things go and maybe convert them to oral medications. Maybe that can be done, especially with efgartigimod, because it looks like it doesn't cause a lot of problem with infections also. Maybe that probably can be a possibility. The only problem with I mean, the thing comes with respect to complement inhibition only because we are exposing the patient to certain infections, and that's the only reason why we can't just go in and give it as a first thing and then later on probably convert it to something else. Efgartigimod probably yes.
And for rituximab, would you give it like that, like as an
Rituximab.
initial?
Maybe, ma'am. So, with the Renomax trial, as I was telling, that smaller dose you probably give it, and we see the disease manifestations get better. Probably we can probably do that. I haven't done it. I haven't done it at all.
I think it may be worth. The problem with all these newer medications, many of them are given IV. It is such a load in the sense of, for the patient, they have to come and get it every 2 to 8 weeks. So I think that it may be a good idea to use them as a bridging therapy, maybe. Because I think at least FcRn and eculizumab, we have data that immediately they start showing response. Now, within the first 1 or 2 weeks, they do start improving.
Yes,
So,
all of them actually.
all those without any data, we can possibly tell that it may be used as bridging therapy as well.
Yeah.
There's one or two questions from the chat box. One is that what are the role of the newer agents in myasthenia?
For the time being, FcRn is the new one. Earliest time, okay, I didn't see it. That is the only question. Okay, here.
One more is that. Can you?
For the time being, no.
That's the only question in that. Is there any? What is the newer agents in myasthenia?
The FcRn probably for the time being, other than rituximab. There's a lot of again. When it comes to a lot of evolving therapies now, there's a thought process where it is not IgG4, it is probably IgG1, G3. So many things that are going on. I didn't touch on any of these because we nearly need strong data to tell to the residents. I just don't want to give a hypothetical data, all data which has not come out and approved. But yeah, maybe times to come we will probably see most of these agents also working in myasthenia because the thoughts are going away from IgG4. Maybe complements will also start working.
Hi, Veena and Sruthi. There are 2 more questions. I'm Asha here. I'm online.
Yes, ma'am.
Yeah. There are 2 more questions. Can you just go through that?
Yeah.
One is
Sruthi also.
Can you please tell if any of these drugs have been tried in crisis or impending crisis? Hello, Veena, could you?
They were not tried in crisis. The crisis still is IVIG and this thing. As we were telling, the bridging therapy. Actually, this bridging therapy was for efgartigimod. There is a data which says maybe we can use it as a bridging therapy, ma'am. So, but then for crisis, it is IVIG and plasma exchange.
I think they use the word medical plasma exchange for efgartigimod because the speed with which it produces takes out the antibodies.
Yes.
Yeah, but as you told, the data for crisis is for whatever conventional agents.
Yeah.
The other question is, what is the earliest time when we can safely start tapering steroids and completely stop them in case of early initiation of rituximab?
Early initiation of rituximab. If you initiate rituximab, see, any agent for that matter, once the patient starts showing a significant improvement, and so there is we do score, isn't it? So we do all our MG-ADL. There is a pass question which we ask if the patient is good enough and thinks his quality of life. So there's also your fatigability test, but there's also a lot of ADL which you have to assess. If at all the patient is good enough, then we will start tapering the dose of steroids. So the earliest time always depends on how quickly or when does the patient start feeling well. So your fatigability test might be absolutely normal, but then the patient might still complain of fatigability. I mean, symptoms which he is probably not good at. So that is why there's a data which says you probably go with the ADL and the quality of life rather than your usual fatigability test. That is when you start reducing the dose of steroids. But when it comes to rituximab, that is what our data, whatever we have, it doesn't give a very glory picture. We probably, because these studies are all done outside India. India, we have done a lot of rituximab to our patients. We don't have a strong data. Madam should tell. Madam, did you start somebody on rituximab and try to taper?
No, we did. The thing is, we still follow the guidelines for tapering as per the usual ones. So when the patient reaches minimal manifestation status, at that point we start bringing down the steroid. So the only question is whether we can bring it down less than 20 fast enough. But that we have not looked at that data to tell you whether we can take it out earlier or not. But the entire idea of using rituximab earlier is this.
We do
that
not
they
know. I mean, it's still the earliest one. Yeah, sorry. Go ahead, ma'am.
Same thing. The point is the idea of using rituximab is this: whether we can bring down the remission fast enough so that eventually, in maybe 3-4 months, we'll be able to bring it down to a less than 10 milligram status of prednisolone.
Yeah. So I think rituximab basically is similar to our thoughts where if we start steroids early, the generalization doesn't happen. Probably rituximab also does the same thing, where probably if you start early, the generalization or the worse manifestation does not happen. So that probably is the thought, isn't it, ma'am? According to the trials and whatever we are trying to do here.
Yeah, that also is there in the sense that if you get control over the disease fast enough, you may prevent worsening, and you may also prevent going into a more refractory or a more difficult kind of a myasthenia.
Yeah. So that's, I think, the whole point of initiating rituximab early on. The steroid tapering, it again follows the same guidelines where we need to understand what the patient is having, and based on that, we need to take.
Shall I ask you one thing about thymectomy? How often do you go out of the guidelines? Like, give it for generalized for ACHR positive, and I usually restricted less than 50 years because of that second study, which showed that less than 50 years may respond better. But do you go out of the guidelines? Do you give for ocular, antibody negative?
No, ma'am. Only antibody positive, generalized, and less than 50. Only then.
And we often get
Not at all
referrals.
outside.
This CT showing thymic hyperplasia. But actually, the patient may not at that point fulfill the requirement for thymectomy. They may only be ocular, or they may have antibody negativity. So CT outside reported as thymic hyperplasia. So do you get those cases, and how do you manage?
Yeah, we do get those cases, especially from the thoracic department. Somebody without any symptoms. So you're talking about somebody with ocular myasthenia and thymic hyperplasia?
Yes.
Or
With
somebody
symptoms.
without any symptoms at all?
With symptoms, but not getting into the guidelines. Sorry.
Not fitting into the guideline. Thymic hyperplasia, I think, I don't know, ma'am. We probably should not, if at all it is ocular.
No, I tend to hold on to the belief that thymic hyperplasia is actually a pathological diagnosis. So this is what I think. And maybe if the thymus is enlarged, we should be looking for a thymoma. That is our concern there, I think. Yeah, but I do not know whether, there are sufficient pathological data to show that whether you can't, if suppose we have an ocular myasthenia with thymic hyperplasia or put an enlargement of thymus, whether there is any benefit in taking it out. I don't think there are studies supporting that right now.
There are no studies, actually.
So residents.
There are also times where some thymic hyperplasia and some other antibody being positive. We had this triational antibody positive, and the patient had undergone thymectomy, because one study had shown that patients with triational antibody positive and thymic hyperplasia with myasthenic symptoms will have to undergo, might progress to have thymoma.
Okay. I can see that Sharda madam is online. Madam, do you have anything to add?
No. It was a very fantastic presentation. New knowledge, actually, as far as I'm concerned. Very comprehensive also.
Thank you, ma'am.
Madam, it's great to see you here, madam. I'll hand it over to HOD Ashalatha madam to say a few words.
Veena, great presentation, my dear girl. And I'm so sorry. I had given the topic long time back, and I myself forgot that I had given it. So that was the last time goof up. So apologies for that.
No.
So wonderful as always. And very glad to hear all this from you, especially as you rightly said, coming back to it was always a proud moment for you. And
Yes.
yeah, wonderful. And as Madam rightly said, Sharada Madam is always there in the morning classes. Her urge to learn, even after superannuation and all, is something I I myself should learn from now. Anyway, Veena, it was wonderful and a lot of new information for all of us. Thank you. Thank you so much.
Thank you, ma'am. Thank you. Thank you very much for inviting me. I remembered when you said I had to prepare, so I prepared it very diligently. And yeah, when you when you said it was not there, what to do with the entire presentation now?
No, Veena, so kind of get back to me. I confused with another person who was supposed to do in November. So he also got confused. What is wrong with this lady? So that was the whole thing. Okay. Wonderful morning. And thank you so much.
Thank you.
Thank you, Sruthi, also. Thank you, Sharda Madam.
Thank you, ma'am. Thank you. Thank you, Shruti ma'am. Bye. Bye.
Bye, 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 bye.